with, not so much all that on the screen right, but I want you to know the nail plate is the actual fingernail, but we call it a nail plate. That right underneath it is the nail bed, okay? The nail fold is kind of just where that skin all around the nail, where it kind of bends over, tucks in. The lunula is that little white part, you know, under of the nail. The eponychium is the cuticle. The nail matrix is where our nail actually grows, is back behind the nail. So here's your nail, and the nail matrix is right back there. Okay, so it's a ways back. So getting a nail biopsy, you know, if you're just trimming some of the nail plate to send it off for culture or to see if it has fungus or whatever, stain it for fungus, that's easy. But when you are actually getting a nail biopsy, you typically get it from the nail matrix. And yeah, I've never done one. There was two guys, or at least one guy in our derm office who did Mohs surgery. He would do that. I think you basically make two kind of slices, you know, and then kind of pull it back and then get a small little 2mm punch, you know, back at the base. I know it makes my skin crawl. Look, it's torture. All right, but please be familiar with those terms because you might see them again. All right, we're first going to talk about various infectious nail disorders: acute paronychia, felon, green fingernails or green nails, and onychomycosis, which we've already kind of talked about, so hopefully will be a review for you. So acute paronychia is an acute infection of the nail fold. It can be at the proximal nail fold, which is, you know, right there like where the cuticle is, or on the sides. The most common culprit is Staph aureus. This is going to be painful, red, and swollen. Have you guys ever had an infection? Yeah, they hurt. They hurt. I mean, it's just like you can feel your heartbeat in it, you know, every time your heart beats. And you can, I had abscess, I probably meant more a pustule, but I guess an abscess would be right. There is pus collection. And it's usually you get, you know, people who kind of pick their nails or the skin around their nails. You just have an open area where bacteria can get in, and then you can get an infection. I had one, yeah, I had kind of picked my fingernail, and oh, it was painful. Really, really painful. If you have an obvious pustule there, the best thing you can do is to puncture that, probably with a 18 gauge or something, and express that out. That like gives, you know, automatic relief, just getting that pressure out of there. Topical antibiotics, if it's just mild, I would probably just do a topical antibiotic like Bactroban. If it's more advanced, or, you know, an oral antibiotic, but I'd probably start with a topical antibiotic. And then again, IND. And you probably don't even need to anesthetize that, because, you know, they're not really going to feel you putting the needle in through that skin. Now, where they will want to kick you is when you're applying some pressure to squeeze that junk out. And that's what it looks like. So these are painful. Painful red. Felon, excuse me, is actually an infection of the pad of the finger. Okay? Or the pulp of the finger. And Staphylococcus is the most common. What can happen with this is through the fat pad, there's these little fibrous septae, and when you get a lot of swelling, inflammation in there, you can actually block off the blood supply to a certain area, the blood flow, and which can lead to necrosis of that tissue. Or go further and down into the bone. So this can be a pretty serious thing. Again, this is even more painful than the paronychia, acute paronychia. Redness, swelling, and again, potential pus accumulation. This is probably most commonly associated with puncture wounds. Even diabetic, using a dirty needle with doing a finger stick, blood sugar, a splinter, anything like that. Or it can spread from a paronychia. This one you're going to want to treat with an oral though, because this one's a little bit more aggressive for sure. Tetanus shot if they're not up to date on that. You might think about a radiograph to look for osteomyelitis, infection involving that bone down there. Probably, especially if they're febrile and just looking more sick. ID it if you can. You will need a digital block with this because they're not going to be happy. And one thing, again, I've never done one of these, but you just need to keep in mind you don't want to go too deep because you have the tendon and the tendon sheath, and you don't want to do that. You also don't want to extend beyond that bend of that distal phalanx. Okay, so you don't get scarring across that bend. But there's two approaches where you can kind of go laterally or just do a linear opening in the middle of the pulp. And that's probably the safest way to do it and gives you best access. Oftentimes what you're going to do is once you incise, make the incision, you'll get some little hemostats or something and kind of very gently open that up to open up that septae, so to again kind of get all you can out. And that is a felony. Doesn't that just look like that hurts? All right, green nails. This is an infection of the nail plate, or underneath the nail plate, with Pseudomonas aeruginosa. What else do we know that causes? It's associated. Hot tub folliculitis. Very good. Very good. All right. So usually there's been some separation. Separation of the nail plate from the nail bed is called Annika Lysis. Okay, that's just where you get separation there, and you tend to get that when your hands are in water a lot, or if people kind of gouge, cleaning their nails, are a little too aggressive, and they start that opening, and then you get moisture stuck in there, and it just gets bigger and bigger. So you get fluid or water stuck up underneath that nail where this bacteria can grow, and it has kind of a green to greenish black discoloration. You want to trim that nail down as far back as you can comfortably, and then soaking in a dilute bleach solution is the treatment of choice. Do that several times a day. I'd probably do half and half, 1 part to 1 part water and bleach. And that's just going to help dry that out. And obviously try to wear gloves, try not to immerse your hands in water, things like that. You shouldn't need an oral antibiotic, just drying things out. And that encouraged, by drying that area of Annika Lysis up, allows it to reattach so that fluid can't get stuck, or the water can't get stuck in there. And that's what it looks like. There's nothing else that's going to, unless you have fingernail polish on, that's going to cause your fingernail to look that color. And then onychomycosis, fungal infection, or tinea unguium. Very, very common, especially as we get older. Remember that Trichophyton rubrum is the most common cause. Trichophyton tonsurans is what is most common on the scalp. T. tonsurans. T. rubrum is for the athlete's foot and the toenail infections. Now, It can be other things, but that's the most common. It can even be yeast sometimes, or candida. With this, you're going to get thickening of that nail. You're going to get subungual debris, you know, kind of crumbles out. Annika Lysis, and a white yellowish discoloration. Pain may or may not, you know, typically people don't experience much pain. Typically involves the distal or the lateral portion of the nail. There is a variant of a white superficial, and this one's a little bit easier to treat. I'll show you a picture of it, the difference. You don't have the thickening of the nail and the yellowish discoloration. You just see a kind of a white chalky look to the top of the nail. Candida is much more common in an immunocompromised person. So if you can clip some of that nail plate, and especially with some of that debris underneath, the subungual debris, and you can send that off for a particular stain to your histology lab, that's a pretty quick response. You can send it off for culture, but that takes 3 or 4 weeks to get the results back. You can do a scraping of that, but that debris is so thick, it takes a long time for that KOH to break all that down, and so I've never really done that. Your Lamisil is probably your #1 choice for that. Again, I don't expect you to know the dosing. Any fungal nail disease is very difficult to get rid of, and the reoccurrence rate is very high, so it can be tough. Even sometimes people will remove the nail, but you still need to treat them, because they're still going to have that fungus, and you have to kill that, even if you remove the whole nail. I would sometimes use fluconazole, especially if a person was real worried about the liver. With Lamisil or terbinafine, you have to be concerned about the liver. You don't want to put somebody with alcoholism or liver disease. I always, with Lamisil, get baseline hepatic function, and then a month into it, I will repeat those. I don't check them every month, but I will check it 1 month into the treatment and make sure they're still stable, and if they are, then I feel fine with that. I think another thing so anyway, fluconazole or Lamisil, that's typically better for yeast, but it can be helpful for this as well. The treatment is a little different though. Rather than a daily pill, you take it, we would kind of call it fungal Fridays. You take 2 pills, 2 200 milligram tablets, just one day of the week. It doesn't have to necessarily be Fridays, but that was just a good day to remember, or a good way to remember it. And do that for several months. Again, with nails, you have to treat for probably minimum 3 or 4 months. Again, depending upon what medication you use. Any of the topicals, I think in my previous thing, it said 6 to 12 months, but it's longer than that. It's like 48, I think. One important thing too is, I think, to educate your patients on is, even though you take the medicine for, say, 4 months, you take Lamisil for 4 months, they are not going to have a normal looking nail, okay? The infection may be clear, but you still need an additional 4 months to allow that nail, that ugly looking nail, to grow out and let the normal nail proximally grow out. Okay, so just because they're going to want to stay on this medication for a year and a half, and they don't necessarily need to do that. Does that make sense? Because I will say, when I see them for follow-up, and I'll just say, your nail doesn't look normal right now, but it's just got to grow out. So we got to give it some time to do that. I always encourage, Jennifer was teasing about throw your shoes away. You know, I think anybody who's prone to this, yes, if you've got some nasty old shoes, they probably do need to be thrown away. But I think a good thing to do is to have them start putting antifungal powder in their shoes every time they take them off. Maybe spray the bottom of their shower, things like that. All right, screen left is what your typical onychomycosis. The screen right is that more superficial. Oftentimes it's not that involved. It may be a little spotty with those little white, chalky looking patches. That actually responds better, or can respond better to the topical treatment versus that real thick nail of your typical onychomycosis. Questions about the infections? So nail-associated dermatoses, we've talked about a couple, all three of them actually a little bit. So nail psoriasis, about 50% of your people that have skin psoriasis will have nail psoriasis. One very important thing to know is that if a person does have nail psoriasis, nail involvement, they're much more prone to have joint involvement. So remember that. You can have only nail involvement. You don't necessarily have to have skin involvement. I've seen that several times. Nail psoriasis can look, now the pitting is pretty remarkable. You know, that's probably the main thing you're going to see, but other changes can look identical to fungal onychomycosis. It gets thick, you get Annika Lysis, you get that subungual debris. So unless if a person has skin involvement, where you're like, okay, that's why your nails look that way. If they have only nail involvement, it may be difficult to tell, is it fungus or is it nail psoriasis? You might need to get part of the nail plate and send it off for culture or histology. One other thing, so nail pitting is probably the main thing you're going to see, just little dents, looks like hail damage on your fingernails. You have an oil drop sign or salmon patch too. That's where you have kind of the reddish brown discoloration, yellow to reddish. I guess that's probably more appropriate. In the center of the nail, or in the nail plate, or bordering onycholytic, where it's separated. It may be at the border of that. Nail psoriasis is real hard to treat. Sometimes we have tried high potency topical steroids and we have them rub that down into the base of the nail where that nail matrix is. Because the problem is occurring in the nail matrix, and as that nail grows out, it shows the abnormality. Okay, so you need to treat the nail matrix. Another thing that can be done, I have never done it, and I don't think I'd ever want it done to me, is injections of steroid into the nail matrix. Now, doesn't that sound like fun? You really don't like somebody, I suppose. There are some, any of your medications, systemic medications that you might treat your skin, a person's skin and joints with, will be great for their nails as well. Acetretin is one that is particularly good for the nails. And that is Psoriasis. Is that right? Does anybody have? Double check. Don't want to misspeak. Psoriasis is an oral pill that's kind of a cousin to Accutane that we talked about in acne. And that, again, you need to be careful of pregnancy. you have to be careful of the lipids and the liver, and they may even get a little dried out too. Methotrexate is an option as well, yeah. And that is what nail psoriasis. You can appreciate the pitting. Can you see that? Mm-hmm. The dents, and they may be hard to see. You have to sometimes, get them at the right angle. I would say this area here is like that salmon patch, the oil stain.
Would all of their nails look this way, or just
not necessarily?
some?
No. No, it's usually that they aren't all involved. It's just a few of them, or even one of them. Okay, LP, or lichen planus of the nails. Again, you can have just nail involvement, or you can have skin and or oral involvement. About 10% with mucous membrane or skin lichen planus has the nail involvement. So you don't see that much, thank goodness. I've seen regular LP in various forms way more than I have the nails. And again, this can affect one nail, several nails, or all 20 nails, which is that 20 nail dystrophy. And this is a much more destructive, it destroys the nail plate. You get longitudinal ridging, thinning, fissuring, and loss of the nail plate. That's the main thing I want you. That and the pterygium. Okay, know what a pterygium is, and that it's associated with lichen planus. When it gets more advanced, a pterygium is where you get kind of this V-shaped growth, I guess, of the skin at the proximal nail fold that grows onto the nail bed. Again, you can sometimes just make the call by looking at it. If you want more confirmation, you can refer on for a nail matrix biopsy. One thing to know, I think, by referring somebody for a nail matrix biopsy, that gives them a permanent funny-looking nail, because you are going to cause scarring to that area. So just be aware of that. All right, so first line is either intralesional or systemic corticosteroids. You can try some topical stuff. Your oral retinoids like the Steroid. It's hard. All right, so you can see the early stages on the screen left, where you kind of have that longitudinal ridging, and then much more advanced stages. The nail is just destroyed. The nail plate is just destroyed. Here is the pterygium. See that kind of V-shaped growth of the proximal nail fold onto that nail bed. So make sure you know what that is, and you can recognize it, and what it's associated with, which nail disease. Okay. Alopecia areata of the nails. All right, so about 50% of kiddos with alopecia areata of the scalp or wherever will have nail involvement. About half of them. I haven't seen that many, but it can be. So sometimes it can precede the hair involvement. Sometimes it can occur after the hair involvement. Rarely does it occur by itself without any hair loss. And again, you get you get indentations, the pitting, but they are a little different. They're not as deep as psoriatic nail involvement, and they're in a real regular distribution. Again, if any testing, I'm probably not going to, I'm not going to have you, by just a picture, determine whether it's psoriasis, or unless if there are other nail, findings like you would see with psoriasis. I'm not gonna be that difficult, or I will give you some history that should make it more clear. Were the pictures okay on?
Yeah.
Okay, on the test, they were easy to visualize and, okay. Were there some that had, well, were there some that had more than one picture?
There was
There was like one or two questions that had one and then a thumbnail.
Okay, and that's what I had added the one, I kind of prefer pictures right there as you're reading it rather than having to go to the thumbnail, but I didn't know how to get rid of the thumbnail. So, so I hope that didn't confuse anybody. I was kind of trying to look out there to see if people were like, okay. Okay, where was I? Mainly, don't worry about the other nail abnormalities, just mainly be familiar with the superficial pitting and a regularly distributed pattern. You can get spontaneous resolution with this, oral or intralesional steroids. Worry about that other stuff. So see, that looks different than that psoriatic nail pitting, doesn't it? More superficial, just looks like in a linear pattern. And you don't have the other changes that you see with psoriasis, such as the Annika Lysis, the thickening of the nail, the discoloration of the nail, that sort of thing. All right, some other traumatic environmental nail things. Annika Lysis, chronic paronychia, not acute, but chronic paronychia, and then this median tick deformity. Annika Lysis, we've talked about that quite a bit already, but this is detachment of that nail plate from the nail bed. It looks white because you've got air, it's just separated, so you've got air between the nail plate and the nail bed. Again, this can be mechanical, people shoving stuff down there. Typically you think of it with people that just have their hands in water a lot. You can get, anytime you've got that little open space, especially if your hands are in the water a lot, you know, you get, that's a warm, moist environment, and boy, that's where bacteria or fungus can really like in that environment. You want to trim that down, try to keep it dry. You might try, there is a thymol. Thymol is a prescription medication. I don't have that in here, Thymol. I won't test you on it, but it's just kind of a good thing to know down the road. I will use Thymol just for non-infected Annika Lysis. They just put that underneath the nail plate, and that, I've heard it stinks, but it really helps to dry that nail out, or try the bleach soaks too. But just very slowly, by drying that out and keeping their hands out of water, it will slowly start to reattach from the proximal end. There is kind of an interesting drug-sun photoonycholysis, where I want you to mainly know the cyclines. Okay, cyclines, well, fluoroquinolones too. The tetracyclines and fluoroquinolones, in a not very common, but when you are on that medication and you're out in the sun, the photo part of that, you can have a drug-driven onycholysis. And that's what onycholysis looks like. Chronic paronychia is, again, associated with people whose hands are in water all the time and they maybe pick a lot. This is where you have a much lower level of inflammation around that nail fold somewhere, or all around it. You tend to have complete loss of the cuticle. It may be a little tender, but it's not going to be, you know, quite tender like the acute paronychia. You oftentimes have a secondary infection. You've got inflammation, there's no doubt, and oftentimes you have a secondary infection. The most common that I want you to know is yeast candida. So if I'm going to treat for a secondary infection, that's what I'm treating for. hand protection. Again, have them wear latex, or not latex, but what's the yellow gloves that?
Oh, when you wash.
Huh?
Oh, the ones you like use for.
Yeah, for cleaning dishes and stuff. Make sure you cover up your hands so it's not in the water. Oh, you will oftentimes get some changes to the nail plate itself, again, just from that chronic inflammation that you have going on in the nail matrix. See that? The nail, you don't even see a cuticle there. It's just they obviously pick, they're obviously in water a lot, they've got this inflammation all around the nail fold. And you can see changes to the nail plate itself, and again, that's from, you know, months of having this going on, and the nail matrix has inflammation, so it causes changes to the nail plate as it's growing out. And then this median tick deformity, that is when you see these little ridges down the middle of the thumbnail, and that's from people who just out of habit just constantly poke on their cuticle at the base of the thumbnail. You just have to get them to stop that, which is easier said than done. They don't even sometimes realize they're doing it, because I will say, oh no, that's from, and as you're talking to them, they're like doing this, and you're like,
I got that.
note to self. Sometimes you need some antidepressant type of things, SSRIs, just because it's a obsessive compulsive type of behavior. Sometimes you can put super glue down there so that they can't get to it as easily. And that is what that looks like. I know you're going to see that at some point. Okay, and the nail signs of systemic disease. You know, they always say the nails are just kind of a continuation of the skin, and sometimes you can see what's going on internally with the nails, and there's truth to that. So we're going to quickly talk about Bowes lines, onychomedisis, Terry's nails, Paronychia, and clubbing. Bowes lines are these transverse lines or furrows that indicate an interruption or an arrest of the nail matrix with the growth of the nail, all right? And it's due to some type of stress to the body. It can be a febrile illness, it can be medications, it can be surgery, high fever, things like that. It's usually bilateral. Sometimes it can be just you know, if you damage one nail, you may just have it on one nail, but if it's on like multiple nails or all nails, it's something that went on internally, and every single nail matrix kind of just shut down there for a little bit. There were more important things going on in the body and didn't care about the nails. And that is what Bowes lines look like. Now, from that, you can see the stressful event went on probably 4 to 6 months ago, because it's grown out that much, so you can just kind of guesstimate. So if you see that and they're like, what in the heck are these lines on my, well, what happened about 4 to 6 months ago? Were you hospitalized? Were you sick? Anything like that?
Is that pretty common?
Not real common, but you're probably going to see that more in, say, family medicine, internal medicine than derm office. Onychomedisis is kind of due to the same thing. It's temporary arrest of that nail matrix function due to some kind of a stressful event. This one, instead of a line, you get shedding of the nail plate from the proximal part of the nail. Okay, so that separation starts proximally rather than Annika Lysis, which is distally. This is same sort of stuff, but this is even a more severe, stressful event. One thing to remember is onychomedisis in children is oftentimes associated with a Coxsackie recent infection such as hand, foot, and mouth. And that is what that, see how it's just, it's separating from the proximal. I have seen this several times, usually in kiddos. Okay, terry nails is where the distal couple of millimeters is a normal pink, and then the proximal is real white. And this, sometimes that can be a normal variant in an elderly person, but you're going to see it more with liver disease, chronic congestive heart failure. I probably remember more liver disease. You see that? Paronychia is spoon nails. That's where you just, the lateral edges are bent upwards, thin and concave with edges everted. Think of this with low iron, okay? Faulty iron metabolism, iron deficiency, can be hypothyroid too, but I want you to mainly remember that iron, low iron. There you go. I guess they'd like that if you snorted cocaine or something. It'd be kind of handy then, but. So, you'd have one for each nostril. Okay, now clubbing is kind of just the opposite. This is over curvature of the nail plate and the nail bed, and even the padding is kind of bulbous as well. Thickening of the nail bed. One thing, I don't expect you to know what the name of this sign is, but you might want to recall that, when you put your nails back to back like that, you have this little triangular opening window. When you have nail clubbing, you don't have that. There are certain things, think of this primarily low oxygen, okay? So your pulmonary and cardiac disorders, especially if you tend to be kind of hypoxic with it, especially lung cancer is oftentimes associated with this. And that's what nail clubbing looks like. Do you want a quick break before we go?